Living a fuller, more functional life with perhaps greater longevity. That's the focus of this episode of the HealthLinks podcast, presented by the HealthLinks family of services. Welcome, everyone. I'm your host, DJ Thatcher. Our mission here is to engage in conversations about the medical and wellness landscape of South Carolina, so we're all better informed. Now, in this episode, we are at the Charleston Sports Medicine and Orthopedic Center, joined by its founding physician, Dr. Bright McConnell. Dr. McConnell, welcome to the HealthLinks podcast.
Oh, great. Great to be here with you. Absolutely.
Now, you've got a great website. It's charlestonsportsmed.com. We'll make sure we link that down below. And the first thing that jumps out when you go to that website, it says, combining traditional orthopedics with cutting-edge regenerative medicine.
Yeah.
Maybe you knew that. I don't know. It looks good. Well, hey, as a board-certified orthopedic surgeon, what is your definition of traditional orthopedics these days?
Well, I think, orthopedics is sort of broadly defined as diagnosis, treatment, and assessment of just musculoskeletal.
Right.
Skeletal, bone, injury, trauma, fracture, reconstruction, things that orthopedic surgeons routinely do. The science is constantly advancing, both from a standpoint of technology, much less invasive ways if we have to do something interventionally as a surgeon, but also now opening up to a lot more other types of treatment strategies we have available in terms of treating with musculoskeletal conditions in general.
I think a lot of people forget the fact that orthopedics is not just a bone injury. It's everything attached to the muscles, the tendons, the ligaments, and everything else.
Oh, it absolutely ranges from a trauma like a broken leg to bad tennis elbow, tendinopathy, to wear and tear, arthritis, spine and nerve issues that go with that. But it's how that all integrates in terms of how we functionally get around and do things from that standpoint,
So we want to spend the bulk of our time talking about the newer therapies, these cutting-edge therapies that you have. But first, give us a snapshot of what Charleston Sports Medicine Orthopedic Center is all about, your staff and everything else.
Sure. Well, my background is orthopedic surgery. I did a general internship in general surgery and then 5 years of orthopedic surgery. I did my fellowship, postgraduate training in sports medicine. I did that at the Curl and Jobe Orthopedic Clinic in Los Angeles. It kind of dates me because that's when Magic and Kareem were on the court.
All right.
The Rams were in Anaheim, but it was the Olympics there that year, so it was great. Yeah. Since then, I've been back in Charleston, South Carolina since 1985, practicing orthopedic surgery. Over those years, though, I have seen in orthopedics a lot of progression, like I said, in technologies. So technologies have really gotten, I think, a whole lot better, but also this influx of less invasive types of treatments. And that sort of has really been my focus, I think is the best way to say that, for basically since the early 2000s, the last 20, 25 years.
Interesting. Yeah, as part of your education, obviously med school and your residency and your fellowship, one interesting thing I saw was that you did a traveling residency in Europe during your time. Yes. What did you find there? What was that all about?
Well, it was really quite interesting. Yeah, I had finished up at Gainesville about 6 months early, and our chairman there, Bill Lenny King, he's an internationally known oncology, tumor surgeon. All the tumor classifications are called King classifications. Right. But he was really sort of tied into a lot of the European centers. And I think travel is something I would encourage for a lot of clinicians because you just see, just because we do it this way here doesn't mean it's the only way or the right way. And you really get to see and get exposed to other technologies in different countries and how it's being used. So it's a great time.
Is there a big difference between, just in this case, orthopedic surgery among Europe, the U.S., and other areas of the world? Is it pretty standard, or are there differences that you see?
A lot of it's standard. I think if there's one, and it's not so much a bias, but one thing I do see is that I think, particularly in European countries and to some extent Southeast Asia, I think they have a little heads up on terms of the new science coming out. Part of that is structural in terms of their governance, for lack of a better term. Our FDA has a pro and con to it. Yeah. Sometimes it takes longer to get clinical trials, and we deal with these new things like biologics, and the certification that sometimes takes longer than what they're doing there. I think a great example, for example, is acoustic shockwave, developed in Europe. Originally developed back in the early 80s by Dornier. It's a German company to blast kidney stones. They call it lithotripsy. But it's using acoustic shockwave. And there's some big companies in Europe, one of which we use in the operating room all the time, like Storz Medical, that's now had focus shockwave been developed for us to treat in much less invasive ways using acoustic shockwave. The protocols we actually follow now are really kind of based upon those protocols because they're about 7 or 8 years ahead of us in some of this stuff. But that's just an example, one type of technology.
So you began to mention, but it's interesting, you're in Los Angeles. You got to work with a couple of sports teams, the Lakers, the Dodgers, the Rams, and so forth. What was that like, treating these elite athletes, and what did you learn from them?
Well, it was kind of interesting. I did my orthopedics at the University of Florida, and I went to Davidson undergrad. We didn't have any football. We had a good basketball team.
Sure.
But I went to big school, and when I went to the University of Florida, to come out of the thing into Ben Hill Griffin Stadium and Gators were hitting the field was like a whole new experience. Now, when you go to the professional side, like the example of the Rams, it was just interesting. You knew these individuals, Eric Dickerson, that dates me, the Jack Youngblood guys, those days. The Lakers is a really good example as well, just different personalities. Magic Johnson is probably one of the nicest guys I've ever met.
Wow.
Kareem was kind of an interesting personality to talk to and deal with. So it's a different thing. And Frank Jobe, the Curl and Jobe Clinic, he did the Tommy John operation, did all the mechanics for that. So that's our time with the Dodgers. Spent a lot of time with the Dodgers. Covering those games. It was very, very interesting.
Are those athletes really built differently? Are they wired differently, or is it just their dedication to their training?
It's a combination, I think, of a lot of different things. I think to get to an elite level of athletics and a lot of these types of things, it's really how are you? What's your DNA? How are you programmed? Fast twitch, slow twitch. I mean, absolutely training's absolutely important in terms of where it is. But it's it gets thinner and thinner the higher up you get in terms of what you are able to do in terms of your performance.
Sure. I know you brought a lot of that back to Charleston too. You the team physician for College of Charleston sports teams, right?
I was, I came here in '85 and I took care as a primary team physician for almost 20 years. Yeah. I always feel like I had really good times. I like basketball, and that was the John Kress years and the Cougars.
Okay,
Cougars, it was a great team. It was actually my schizophrenic game, though, because I was a team physician for the College of Charleston, the Cougars. But when we go to Davidson, which was a big rival for us, it was the Wildcats, which was my alumni. So it was a very, very good time. And just dealing with what I call training room stuff, dealing with the athletes in the training room was very, very encouraging and fulfilling.
Well, you certainly have the credentials, the street cred for sports medicine. We get that.
Prioritize your health with a subscription to HealthLinks magazine. Get every issue of HealthLinks delivered right to your door for only $15.99 a year. 6 issues packed full of local factual health information to help you be the best version of yourself. Subscribe now to HealthLinks magazine. Visit subscribehealthlinks.com. That's subscribehealthlinks.com. HealthLinks magazine, the Low Country's prescription for well-being. You're watching the HealthLinks podcast.
So tell us a bit now. You're doing a lot here at Charleston Sports Medicine with newer therapies. And one thing you mentioned was this whole concept of longevity and how the medical field has moved from, preventive medicine to attentive to, what were some of those others that kind of on that
holistic
path?
and longevity. I mean, longevity medicine's kind of come in. Functional medicine, anti-aging. You can't stop aging.
Right.
So there's no anti-aging, but how do you manage it? How do you manage the aging process? And I think that's really what longevity medicine has sort of developed into with new science, with new things we can do as to how do we really impact the issue about aging, maintain high levels of performance, slow down aging processes, different ways of dealing with the things that tend to maybe start to talk to us, particularly over the age of 55, because that's what defines seniors now, 55 plus.
55.
So I'm a senior.
Thanks a lot.
I'm a senior.
We're both, started getting the AARP stuff years ago. It's like they hit you in the 40s, I think.
In 50s. That was my wife. She gave me a gift certificate, AARP, and my birthday card for my 50th birthday.
Happy birthday. Oh, man.
Happy birthday. But no, it's the science that we have to deal with it. Right. And life expectancies until recently have been increasing, and so we've got a lot of tools in our toolbox. I'll tell patients now to make that time much more pleasant for us.
Sure. We joke about aging and how the 60 is the new 40 or whatever, that kind of thing. But a lot of people, don't they assume that just as they get older, they're going to have the pain, the decreased functionality, and it really doesn't have to be that way, I imagine. And I know you're doing a lot here with tell us about the FitMed program. You have Vasper, all these things that you notice on the website. Again, we'll link that down below here.
Sure.
What are some things that can help people of maybe our age or even younger to stay fit?
Yeah, for a while around 2003 to 2007, I was involved with a big preventive medicine center called Prevacare. It was a local thing, really looking at early identification of disease and how do we modulate it now. So I've kind of morphed that preventive type bias basically into, like I said, early detection. And I think the issue is a lot of people say, what is it? Well, it's like looking at, I call it the three legs of a stool basically, which is like nutrition. And not just macronutrients like what's the diet of the day, but how does that affect us and risk of diabetes or insulin resistance, micronutrient therapies, so-called nutraceuticals, different types of things that have an important role for us. And now we have actually genomic markers we can identify from genetic testing, which we might need more of. Then there's the thing about exercise science and fitness, just general fitness and our abilities to do things. And that can be arranged from a lot of patients I see, from high-level, elite-level fitness to people who can't stand to exercise, but they know they need to do something. And what's the new sciences in terms of fitness? And that kind of, we can talk about those in just a moment, but that kind of goes in some of these new exercise science technologies that are also being brought out. And then the last thing, which is, I want to say controversial, but it's been, I think it's standard now. There's a lot of misunderstandings about it, is hormone replacement therapy. Real important in longevity medicine. Hormones, are they good or are they bad? And you just have to, there's a lot of good science out there that supports appropriate use of the appropriate form of a hormone, and there's a lot of confusion out there too about the use of hormones.
I know you have a comprehensive practice here with not just yourself and another doctor, but also your staff as well. You provide physical therapy. You have the licensed PTs.
Yes.
What about, though, somebody coming in who wants a workup and, hey, what should I be eating? What macro or micronutrients should I be taking? I know you offer those here and so forth. What's a workup like for somebody who's coming in, for help?
Yeah, I mean, part of that is, as you mentioned, it's kind of try to get an idea of their nutritional background. And again, some of that's just sort of standard dietary questionnaires that have been evidence-based. Again, we now have genomic testing in terms of how are we wired, because that's a huge difference.
Interesting.
And there actually now is a sub-brand of that called nutrigenomics, where they can say, well, you've got this genetic modification that makes you much more sensitive to, say, a deficiency in B complex or something that converts folate to metafolin. It's a genetic issue. So you can, instead of just trying a bunch of different stuff and see how you feel, we can kind of narrow it down from that standpoint. So there's actually tests out now to look at what we're calling biological age by measuring these things called immunoglobulins, like glycan age. Glycan age is a big company that does that. So that's on the nutrition side. The fitness side, we do basic things like resting metabolic rate, where are you at, to all the way to elite level things like what they call VO2 testing and that type of thing. We'd have a body composition technology like DEXA, we call it, the body composition. And BMI is just sort of meaningless, to be honest with you. It's really more, what are you made of? Forget what the weight on the scale is. What's the percent of this? What's the percent of this muscle? And that gives us a good metric to act as a baseline, so we can look at it over a period of time and see how patients are progressing. There's
so much information out there. It's very confusing for people. You go on YouTube, you follow the latest trend for nutrition, as you mentioned, maybe exercise, you join a gym or you follow someone on the social media, maybe just start taking supplements at random. So when you're coming in here, are you getting blood tests and so forth and that sort of thing to really narrow in, I guess, on what should be taken and what you should be doing? What is that whole process like, and maybe some of the costs, or if anything is covered by insurance and so forth? Sure.
I mean, first of all, there's a real initial profile that we call it within FitMed. There's a profile panel that's pretty comprehensive. I tell patients that's our major vampire draw. Because this could be like a 20-tuber.
Oh, wow.
But we're looking at some of the general labs that a lot of people might be looking at, but we're looking at these newer labs, particularly the number one issue is cardiovascular risk assessment. So we're looking at inflammatory markers, something called CRP, and homocysteine levels, lipid panels, and not just your standard lipid panel, but it used to be called Berkeley Heart Labs. Now it's Cleveland Heart Labs, but it's looking at fraction size and looking at trying to predict cardiovascular risk. Again, fairly comprehensive nutritional assessment and a real comprehensive hormone panel. And not just testosterone or estrogen or growth hormone, but thyroid, adrenal function, those types of things are all kind of looked at. And that's kind of what we look at from a standpoint of blood levels to determine that. And then some genetic testing I kind of mentioned a little bit earlier.
Interesting. So that's the initial workup, I guess, when you consult with someone consults with you. They come back, I guess, then you walk through all of these results and develop a plan then, or
exactly. How does that work? So they'll come in for some of that initial testing. We get the blood work, and we usually meet up in the office. I do have some people from around the state, and we're actually exploring, because a lot of things now are going remote, because the labs that I use, there's two big national labs, Quest and LabCorp. I have to use Quest. It's interesting, too, about insurance coverage. That's a little bit of an issue for us in terms of, not that it shouldn't be an insurance, but sometimes insurance dictate to the providers and the patients what they can do. Like, we'll say, well, you can only check your PSA every 2 years. What? Yeah. I mean, if you had that test, you can't have that test. So it's sometimes kind of a mixed model. If they come in and they've already had labs that are relatively recent, we don't have to repeat them, but there's some newer labs out there that insurance companies still look at as, well, that's investigational. So that's kind of how the pricing kind of works. It's sometimes kind of a hybrid from that standpoint. So once we get all the information together, then we'll try to have just a consultation, we call it, and again, trying to look at some of that remote now, because COVID brought that in, telehealth, and a lot of patients, whether they're coming from Columbia or even Kiowa, Seabrook, or whatever. Just be able to do it on a Zoom call or something like that. We can do things that we don't have to physically have them here for. So we'll go through that, and then I make them recommendations based upon what the data suggests. Whether it's nutraceutical-based supplements, because some people will come in and they'll look at me and go, I'm going to give you 4 things to recommend. Okay. And some people come in with 3 bags of stuff. Look what I'm taking. And you got to kind of go through them, what's there. Anything that's prescriptive that needs to be written by the prescription, we take care of. And if they elect for us to do that, then they kind of go into what we call the program. Okay. In the first year, we meet a couple times a year. But after the second to third year, they're kind of in that, what I call the rocking chair, and we've kind of modulated their levels where they need to be, and I might just see them once a year for that.
Don't say rocking chair. That's not a good message.
That's right.
Get that.
Well,
A lot of things I wrote down off the website here, just so I could pronounce them and make sure I don't get them wrong. A lot of what you offer, besides traditional treatments that you said, orthobiologics. That's a mouthful. So an orthobiologic, shockwave therapy, you touch base on that, MLS, laser therapy, EMTT, things that many of us have never heard of before. Walk us through some of those treatment options, what they're for.
Yeah, orthobiologics, and the kind of abbreviation is OBX, and that's not the Netflix Outer Banks show.
I was going to say, right. That's what I think of, yeah.
But orthobiologics are basically substances, primarily, that are biologically based or naturally occurring. Okay. And they come into different categories. A lot of these are growth factors that are derived from blood. People may have heard about PRP, or platelet-rich plasma. Our platelets have these little different individual things. When they break down, the platelets break down, these so-called alpha granules. They release all these stimulatory cytokines, what they're called, that help growth, help vascularity, help new blood supply, tendon, et cetera. All the way to stem cells. And there's only really 2 mesenchymal stem cells that we use. That's in the United States. We don't do any, only for certain research things and trials using fetal stem cells, or embryonic, I meant. So the 2 stem cells that we use are bone marrow aspirate, comes from your bone marrow, and actually lipoaspirate. Most people don't know that, but fat cells, microfragmented fat is what it's called, is extremely strong mesenchymal stem cell. And so we can use those and then some things that are traditional, like gels, highly uric gels for the treatment of osteoarthritis. Those are considered orthobiologics as well.
The stem cells, just to clarify, so they're autologous, or they're coming from the patient themselves. Yes. And being injected back in, or however you use them. So,
true. The only stem cells that we have are autologous, which means you take it from that patient, you give it back to that patient. There is a little bit of a lap, and there's some misunderstanding with this, with amniotic-based products, central-based products, and something called ECM, or extracellular matrix. That's actually a cytokine, just like PRP, but just a lot more into it. those are actually used, and for example, amniotic matrix allograft is used for wound care. And these are donated grafts at the time of a C-section birth. I always make sure patients understand the babies are in the nursery.
Gotcha. Right.
Babies are fine, they're in the nursery. This is mom being screened and donating this. And that's an example of use because it is so regenerative that it's covered by insurance for wound care.
Oh, wow. Okay.
For wound care. But it's considered investigational for other applications.
So for the layperson who's watching, they may have heard of injections. I know there's a lot of radio ads and TV ads about different practices and so forth. Yes. What do they do, they meaning the stem cells and so forth, what do they do when they're injected back in? Where do they go? Does it help to prevent a joint replacement or something like that? Walk us through that a little bit.
Sure, that's an excellent question because, as I said, there's a lot of misinformation about stem cells and what they are. A lot of times people will advertise things on the radio or on ads, whatever, print media, about come to so-and-so and get stem cell treatment. And they're sometimes they're using cytokines like PRP and call them stem cells. But basically the way it works is we have these things called MSCs, mesenchymal stem cells.
Okay.
And as I said, there's basically two. What they do is they secrete this little vesicle called an exosome. Now, exosomes are getting really big. There's been a lot of research on them recently. Pharmaceutical companies are all over exosomes because once you understand the structure, you can biomanufacture it just like any other drug, which they are doing. It's going to take them 3 to 4 years to get through that. But then the exosome is the trigger or the spark, for lack of a better term, that actually activates these things called pericytes. That's Pericytes.
Okay, not parasites.
So those are bad. No, pericytes. But those are tissue-specific cells. So the pericyte, say, in your heart muscle is different than your regular muscle, is different than your cartilage, is different than other things. So it's not like you just inject a stem cell and it knows where to go. It's that mechanism of how that, and that's kind of what the overview of that pathway is.
All right. And there's a lot of other things you offer as well. On the website, there's this great video of a woman going to town on this machine. It's all part of the Vasper therapy or machine, or what is that all about? What's it for?
Vasper is sort of an interesting technology that was developed with funding, joint funding from NASA and Department of Defense.
Okay.
NASA wanted something for zero-G because they're having some issues with mission links, as we just know.
Right.
Paying attention to. Where they're losing muscle mass and bone density because they're in zero-G for so long.
Okay.
And DOD wanted something for wounded warriors, a difficult rehab group. Now, in sports medicine, there's been a training technique called BFR, blood flow restriction. And it's a technique that's been used where athletes will put on, or anybody can do it, but it's been used in sports a lot, put on tourniquets and do high intensity interval training. But the tourniquets hold back artificially the lactic acid. So these now exercise technologies are called biohacking technologies because you're tricking your brain. So the gist of that is once you drop that tourniquet, I'll tell my patients like a dam in the river, it builds up, you pull the dam away, downstream it goes. Well, it goes to your brain, your pituitary, and your pituitary sort of thinks that's a much higher level of exercise to get the lactic acid that high. So it puts out a huge anabolic response. So growth hormone, testosterone, those go way up. That's how your body heals, repairs, and gets ready. And it's been used in sports because it's WADA compliant, the World Anti-Doping Association. You're not taking growth hormone or testosterone. You make, and
who knew there was such an alliance? I don't know. That's interesting.
That's, but you do
World Anti-Doping Alliance.
The World Anti-Doping Association. Exactly.
Yeah.
And it was a performance enhancement. So I'm kind of down that rabbit hole. I apologize for that. But what Vasper and DOD did was that a lot of the wounded warriors really couldn't do high intensity intervals because they're deconditioned from multiple injury. So the individual, Pete Wazowski, Dr. Wazowski, he developed Vasper. He was an environmental consultant for NASA, and his PhD was in cryotherapy and muscle physiology. So he did all the stuff we use in surgery called game ready and cold compress. He said, chill them. If you chill the individual while they're exercising, they don't have to get rid of their body heat. It's called thermal
Interesting,
regulation.
So I'm glad you mentioned on the video, just on the website, shows a woman on this elliptical type machine or bike or something with the cuffs on that you talked about, and it looked like a cooling type of device that she's sitting on and leaning
That's exactly
against.
right. So instead of the cuffs going up with air, they go up with 41-degree water. And I kind of make a joke, the Vasper people took a $5,200 new step, the conventional cross trainer that you see people use, and it's a $50,000 now machine because it's got all this stuff onto it, But that's been it's called anabolic exercise. In other words, because of that response you get, it's a really good way to hasten repair, build back muscle mass.
Okay.
It's only 20 minutes, so that's been a big plus.
Interesting. Okay.
And I actually went out, just as a side note, I saw this as a keynote address using Vasper for the Wounded Warriors Project. It's one of the things they were talking about being very helpful, and I got invited to go out. It's at the NASA Research Park out in San Jose. I went out there for a week. This is about 8 or 9 years ago. And I got approached by Stanford University and the people working with them about doing a trial for osteoarthritis of the knee to build their strengths up in a non-performative way. So that's what brought Vasper to South Carolina, is we started a trial for that.
What determines, so a patient comes in, gets some blood work, they want to increase their longevity and so forth. How do you determine which therapy to go with? So whether it's the Vasper, maybe it's the shock therapy or laser therapy, other things that are shockwave rather, that you spoke about. What determines what direction people go in?
I think again on the exercise line, first of all, and this is I think one of the most exciting spaces I've seen develop over the past decade, because it's aimed, what's driving the business is the boomers. Candidly. Doesn't mean it can't be used on elite athletes, but the boomers. What do you do to keep this demographic healthy, keep them functional, because, want to stay healthy and functional with it. So Vasper was one we just talked about. There's a strength technology called adaptive resistive exercise, arxfit.com, which is just unbelievable. We now know muscle is actually an endocrine organ. It secretes just like a thyroid does. We've actually got genetic markers. We didn't know about this 20 years ago, much less, it's just recently. But the bottom line is, for the benefit of the patient, that these are now technologies they can actually do just once a week, 3 types of lifts, a press, 2 presses and a pull, bench press, leg press in a row, do no more than 4 reps. They're very slow. And they're building muscle mass back to they call it the Paleolithic privileged genome. You can actually, as you're older, regain significant muscle mass that we've lost over time, So that was one. And this thing, a technology called the Carol bike. We mentioned HIIT training, high intensity interval training. There's a big focus on REHIT, reduced exertion, high intensity training.
Interesting, okay.
And there's a Carol bike developed in Great Britain. It stands for Cardiovascular Optimization Logic, but people can Google it up. It's just like the woman's name, Carol, where you actually get on this thing and you do a 3-minute warm-up, you do 2 15-second sprints, you have a 3-minute, you're off the bike in 8.5 minutes. And it outperforms individuals who are joggers or runners that are running 45 minutes a day at just above their heart rate. And I try to explain to people, because I think these technologies now have a real important role for people who might be time starved, just can't get to the gym like they want to, or sometimes people just don't like exercise.
Imagine that.
But they go in and say, you mean I can come in here once a week and do 2 or 3 of these exercises and outperform my buddies that are going to the gym 4 days a week? Yeah, you can.
So what do people have to come in here for to utilize the equipment versus maybe you're guiding them with equipment they're using at home or at a local gym? Yeah,
we do both. That's actually one of the reasons I started a research division of physical therapy about 10 years ago. And as an example, some of these exercises, like there's a machine, there's a grant and all that kind of stuff, they're kind of expensive, and outside the fitness clubs. So a model that I thought would work well would just be have these as part of physical therapy. Because physical therapy for a lot of patients is covered by insurance.
Sure.
I've been here a long time, since 1985. There's excellent therapists in the Tri-County, Charleston area. It's not that, it's just what types of equipment do they have access to.
Sure.
So a lot of them will come in for that purpose initially. As terms of the orthopedic practice, we'll get referrals to physical therapy, and they get exposed to a lot of these technologies there. We are developing a medically based fitness program for FitMed, where we're looking, there's been some interest in this. I've seen these kind of go out across the countries, where instead of building 40,000 square foot, not to pick on any brand, but Planet Fitness, gym, whatever, these, where people come in and lots of machines and during the day, they're starting these fitness centers that are like 2,500 square feet. They might have 4 pieces of equipment. People come in once a week and they go through their routine in 60 minutes to 90 minute stops, and they're finished. So we're seeing those business models spring up.
It's been fascinating to hear everything that is available and things that maybe we're not aware of. So.
It's just, yes.
You got the great clinical background, obviously. You're pretty well-rounded this. I understand you're also a licensed pilot.
Yeah.
And you're a licensed boat captain from the Coast Guard. And you drive a tractor as well. So you can operate all sorts of... One thing, a story you told me before we went on air here was... about how you used to fly for these missions to harvest really from deceased people, harvest what you need from an orthopedic standpoint. Tell us a little bit about that. Really fascinating how that came about.
It was kind of I had a real interest in general aviation, even actually in high school. I got my private pilot's license in high school.
Wow.
And because I was going to the military and do all this kind of stuff, and when I was 6'5", I couldn't read the big E on the chart. So they said, "You're not flying jet for the military, buddy." So I decided, all right, I'll get my, So actually at the University of Florida, again, Dr. Enneking, a big oncologic surgeon, that I got my instrument ticket there and had a plane in Florida, so we could go out and when a donation was available, limbs basically for tumor reconstructions, taking femurs and thighs and cartilage grafts, etc. I thought the University of Florida had a twofer. I could fly them there, and I was the chief of residence. I could do the surgical harvest at the same time.
Nice.
And it was, real quick thing, but sometimes kind of funny because we'd come in from University of Florida, a little single engine, Cessna 182 is what we were flying, and all the universities would be there in their corporate jets, sitting there getting the hearts, the lungs.
Here's you coming in with a Pinto, or whatever.
Yeah. So that's how that happened at the University of Florida, and then I just I liked aviation and a lot of times pilots got two different kinds of things, one plane to go from A to B, like the family to the Bahamas. We like diving, we're all scuba divers, blah, blah, blah. And then sometimes just fun planes, and I was interested in aerobatics, so I kind of got involved in aerobatics as well.
Interesting. Wow. All right. Well, for someone who is watching or listening to this and thinking, man, I could probably benefit from that. What's the procedure? Go online and they come in and consult with you or maybe someone on your staff first? How does that work?
Yeah, no, I think that's exactly right. I mean, the website is there. It's constantly morphing because we're constantly changing different things and kind of where it is. And then the basically, if the interest is expressed, we send questionnaires out. And if like for example, if it's FitMed and they want to do the profile, there's a pretty comprehensive document that can be done electronically to get all the medical information. And then on the orthopedic side, just musculoskeletal. So it's like two different companies. Okay. And I stay in insurance for all the musculoskeletal orthopedic surgery things. So if that's the primary issue, and particularly with the biologics, And to me, the disappointing thing with biologics is everything we use is FDA approved. So it's not a question of that. Is there evidence out there it works? Absolutely. But they're still considered investigational by the FDA. So I'll tell patients who are trying to keep their knee for another 10 years and don't want quite yet the joint or whatever it is from the surgical standpoint, that we can get approval to do a $50,000 total cost now. I'm not talking about of a knee replacement, but they won't cover a $4,000 evidence-based biologic treatment for it. That's changing. There's things in the works now with trials that's going to change that, I think.
Interesting.
Yeah.
All right. Well, we are at Charleston Sports Medicine and Orthopedic Center with Dr. Bright McConnell. Dr. McConnell, thank you so much for
it's great being
joining us here at HealthLinks Podcast.
You betcha. Take care.